Tere kõigile, siis lubasime alustada natuke varem ja järgmine esineja on meie Soome kolleeg Nikula, kes töötab Helsingis ja kes on tõesti töötanud ka laste erakorralise meditsiini arstina Torontos. Et ma puhun vähän, ma räägin ka natuke inglise keeles, et ta ise ka aru saaks, et Nikula on she's from Helsinki and she has trained 1 year in Toronto Hospital as a pediatric emergency physician. And she's doing a very good job to introduce the pediatric emergency medicine training in Finland. Floor is yours.
Thank you. Thank you for the kind invitation. And I'm really sorry, I don't speak or understand Estonian, even though I maybe should, so I'll have to go with English, so bear with me. Okay, I'm going to talk about pediatric emergency medicine and the situation in Finland at the moment. I will cover shortly general situation about the emergency medicine services in Finland, go to pediatric emergency medicine services, and then talk about the future of pediatric emergency medicine in Finland, which is kind of a big question mark still as well, but I will go a little bit into that as well. So we'll start with the general emergency medicine services. Why I bring this up is that it is actually similar whether it's a pediatric or general adult emergency center, so the system works pretty much the same. So the Finnish healthcare organization or healthcare system changed in 23, and after that we've had 21 counties who are responsible about the urgent and emergency care and the general health care in their area. And this represents all those 21 counties and all the hospitals that we've got. There are 5 university hospitals in Finland. Then we have something that is called hospitals with extensive emergency care, and that means that they've got about 10 different specialties on call 24/7, and one of those specialties is pediatrics. Then we've got hospitals with emergency care, and they got general medicine, surgery, internal medicine, and pediatrics. Some of them have obstetrics, and gynecology. That depends whether they are labor or not in those hospitals. In addition, there are hospitals with 24/7 urgent care that are covered by GPs. And then we have all the health centers in Finland that have some kind of urgent care, but only a few of them have 24/7 urgent care. So we actually have 5 different levels or types of emergency departments. And I will get back a little bit later about how the pediatric part looks. So, and in addition to this, that all is public. We've got fairly strong private side as well, especially in the big cities. I'm not going to talk about more about that today, but just kind of to lift it up as well. The way to the emergency department is there are several possibilities. Basically, you should have a referral to come to an emergency department, especially those emergency departments that are covered by different specialties. And you can get the referral from health center or from a private doctor, for example. But there is a possibility for walking as well. That is pretty much after office hours. But if you do want to walk into the emergency department, it is recommended that you call a number 116, 117 first, which is a general medical helpline. And I will talk a little bit more about that in a bit. And obviously you can come in with the ambulance. I saw that Ulle showed the numbers from pediatric emergencies, and if I understood correctly, quite a huge, 90% almost, of the children are coming in walk-in. I think our numbers are not quite vice versa, but something like 20-30% can walk in, and the rest either with ambulance or with a referral. Walk-in, as I said, it is recommended that you call 116 117. This is a number that you can call in whole Finland. And that's based on a nationwide guideline collection that gives the grounds for the urgent care. That actually we have nurses answering that number 24/7, and they will guide the patients what they should do, where they should go. There are a panel of experts who maintain and develop these guidelines. I'm one of the pediatric ones there. And all the guidelines are actually based on research and all the different guidelines that we have. And they actually, I don't have the exact numbers because the counties actually govern them on their own, but it said that about 1/3 they can just give instructions and it's all covered. 1/3 they will tell to get contact with their primary health care next day, and about 1/3 is sent to the emergency department. So it actually covers quite a bit, and if you want to say, stops quite a few patients from going to the emergency. And we've had this since 2018, if I remember correctly. And it is a online database that the nurse can go in. When they get a call, they can choose the age of the patient, and then they can choose the symptom why the parent or the adult is calling them. For example, cough. And then they will get a table and all the instructions how they should go. And every single time they get the first questions that they need to take care of and ask, those are the red flags. And if anything of them is positive, they will tell you should go 112, which is the nödnummer. Sorry, my language. Hätänumero. Emergency numbers, sorry about that. So those are picked out first from it. And then they start going through the guideline, and they can either tell the patient you should go and see a healthcare professional right now, either to the primary healthcare center or to the emergency department, depending on the county how they have organized it. They will tell them if they should go to the ED, but not in the middle of the night, if they think that they can actually wait until 8 a.m. Or then they can say, okay, take a contact with your primary healthcare center and you should see a professional in 1 to 3 days. Or then they'll give home instructions. So this is pretty much how it works. Not everyone, it's not a have to, not everyone calls them, but it's a good source. And it actually helps the emergencies to cover the patients that are coming in. Then obviously we've got pre-hospital care. I'm not going to go more to that, but the 112, the Emergency Response Center agency, they actually also screen the calls that the ambulance is not sent to the spot every single time. And also when the ambulance arrives, they do not have to take the patient to the hospital if they think that it's not necessary actually, that they can cover it there as well. But now I will go to the pediatric emergency services. This is how it looks like in Finland. We've got 5.5 million people living in Finland, about 1 million children under 18 years. When I talk about pediatric emergency and pediatrics, it's under 16 years of age, but the statistics is under 18 years, so that's why 1 million. So there are 5 tertiary hospitals, 5 university hospitals in Finland, and then there are 17 EDs in addition to that actually do see children. And I would be lucky if I could say that all these pediatric emergency departments work similarly, but they don't, sadly. So we pretty much have 22 different ways working in the peds emergency. These are probably the most common type and they all have developed something from these. And there is actually only one site that works in a way that every single child comes in through the same door, goes to the one emergency department, and that's Helsinki University Hospital. So they do not divide into trauma or pediatrics. Every single child goes in through the same door. But also there, we do have pediatricians, we have pediatric surgeons, we have pediatric neurologists working on the floor, and we've got GPs. And pediatricians, sadly, do not take care of trauma at the moment. But this is the Helsinki University Hospital is the largest pediatric ED in Finland. They've got about 45,000 children a year. And it's the major trauma center, so that's why we also need the pediatric surgeons on spot. There is one hospital that works this way since last week, that there is one door, all children go through one door, and there is an emergency physician, an adult emergency physician, if that's what we want to call them, who actually takes care of these children. I started working there last week, and the aim is that I will teach them pediatric emergency medicine so that actually in a couple of years they will be masters of taking care of all those children that come in. But there's one so far. Hoping that we'll get more of those. This is probably the most common. Children coming in are divided into two, into pediatrics and in trauma and surgery. So that's probably what most of the countries in Europe are doing, sadly, still. And the point is that when we got pediatric patients, pediatricians are taking care of them. When we got trauma, surgical patients, it is adult surgery taking care of them. And the problem there is that they don't know children that well. Especially what we see with trauma cases is a poor pain management. In these places, they also often have GPs that take care of the easier patients. Then we see this, that major trauma goes to surgical ward or emergency, and pediatricians take pediatric patients, but they take lacerations, for example, abdominal pains, but they don't do fractures, so fractures go to adult surgeons. And again, now we're sending major trauma, fracture patients to doctors who don't work with children that much. So when it's a major trauma and an extreme emergency, doctors who don't know children that well are actually taking care of them. And again, with fractures, the pain management is an issue. But this is what we see at the moment. So we've got 3 different types. And what we actually do want is this, and either with an emergency physician or pediatric emergency physician taking care of those children. So the children come through one door. Because they don't tell us if they have abdominal pain, what it is. And if you are a pediatrician, you've got some diagnosis. If you're a surgeon, you've got another diagnosis for that. So they kind of bing bong back and forth, because no one really, it's not pediatric. You take a look. It's not, I don't find anything either. It's not anything that needs to be operated on. Back to the pediatrics. So you get my point, I think. Okay. So that was what we want in future. But one of the questions that we are talking about in Finland is that what is pediatric emergency medicine? To me, it is clear, but a lot of pediatricians think that pediatric emergency medicine covers only what's pediatrics. what we think as pediatrics. It's the fevers, it's the coughing, it's the vomiting, it's all that kind of things. But pediatric emergency medicine is all this. So whatever the child comes in with, that is pediatric emergency medicine. I haven't really succeeded with this message yet in Finland. As I said, a lot of pediatricians do not think this way. And I think that I've understood that that's a little bit the same situation here. And that's a challenge. I don't want to be rude to anyone, but if we think of fractures, the diagnostics is actually fairly easy compared to a lot of pediatric diagnostics. Sorry, all orthos and surgeons who are here, but it can be difficult as well. But I mean, it's not as difficult as pediatricians often think that it is. That's the main point of it. So why should we have pediatric emergency physicians? There are studies about it. They have shown decreased use of radiation imaging studies, improved care of febrile neonates, improved care of children with asthma, and lower rates of lab testing. So the two middle ones are US studies comparing pediatric emergency department to general emergency department. But the number 1 and number 4, they were kind of a pediatric versus pediatric emergency medicine physicians doing that. And then there are a lot of studies showing that actually in pediatric emergency departments with pediatric emergency physicians, pain management is way better than in other emergency departments. Another reason why pediatric emergency physicians is actually that there is a recommendation that any ED that sees more than 11,000 children per year should have a PEM-trained consultant, at least one, hopefully more. But if I look at Finland, we only have 10 emergency departments that see more than 11,000 pediatric patients a year. So that's obviously a challenge how we should do that. And I think that one way is using emergency physicians and training them in peds, because that at the moment in Finland seems to be a little bit easier way, in all honesty. And that's what we are doing in this one hospital where I started at the moment. But we do have pediatricians who are interested in pediatric emergency medicine as well. We've got younger colleagues. I think we have about 10 now who are actually driven to this. They want to do this. And I'm actually trying to get them all abroad at the moment to go and learn somewhere. As Ulla said, I've been in Toronto in Canada for a year, and then I worked in 7 years in Stockholm. And Stockholm actually does have a pretty good pediatric emergency medicine training at the moment. So that's the way I'm hoping that we can increase pediatric emergency medicine in Finland for the time being, and then start building it up. For as far, I'm the only trained pediatric emergency medicine physician in Finland, so I can't do it all. But I'm trying to help the younger ones to go further. But I think that we do need pediatric emergency medicine. A lot of those things that I've said, but also the reason is that pediatricians don't really want to work in the ED. And that's one of our problems at the moment. So we need doctors who actually do want to take care of these children and do want to work in the emergency department. I think that was my message, and I want to thank you all for listening. Thank you.
Thank you, Anna, and all the questions will be afterwards if we finished this session. And the next speaker is Lina. Lina is coming from Kaunas. She's really multi-professional. She's working in ED in the Kaunas University Hospital. She's coordinating rare diseases unit, and she's also teacher. And the floor is yours.
Thanks, Ule, very much, and I'm super happy to be here. As Ule said, I'm multitasker, but my passion and my heart goes to pediatric emergency. I am pediatrician, general pediatrician, and pediatric pulmonologist by training. I never did pediatric pulmonology because it was not my passion, as I understood after finishing. So my passion is pediatric emergency, and I will show you how we deal with that and what we do. As we talked with Ule, so Anna is very structural because she's from Finland, and I will show you, because Lithuanians are called Baltic Italians. So you're gonna see if it's true or not. I don't want to put this into your mouth like you know, but you will check on that. So I am a teacher as well. I teach like respiratory emergencies, you see, so I did not go very far away from pulmonology, but still, I teach fellows, I teach students, I have my own lab group, etc. What do you want? So come to us, we have everything, and a good emergency, I will show you. So first, I want to introduce who we are and where we are. Maybe you don't know, so we are situated in Kaunas, in the center of Lithuania. And we are quite good in positioning because we are one of the biggest regional hospitals, tertiary care hospitals, and one of the biggest trauma centers. That's why we're talking about pediatric emergency, because we cover quite a lot. You see the numbers of the hospital, it's from the like annual report. They are quite prominent, yeah, not only from the region, but in general from the whole Lithuania, because we do cover a lot of diseases, very specific diseases if we talk about rare diseases, for example, but in general we talk about traumas as well, because we cover majority of traumas of the country. So this is a city in the city, it's called, because if you come to us, so we are in Kaunas, but there is another city which is happening with their infrastructure. Yes, because we have a bus running there, a new one for 1 year, but this is not the point. But I mean, this is a city really like that. So if we talk about emergency, you see, this is our trauma and emergency care center. It's for adult and pediatric, but pediatric is totally different. It's separate unit. It functions as separate unit with separate facility, with separate personnel. It's not together. It's not like adult physicians are running this unit or adult nurses are there. No, it's totally separate. And we have 18 beds on site, 18 beds for observation, so 14 beds for 24-hour observation and 4 beds for smaller observations, like for 4 hours, you know, for decisions what to do further. We have 2 physicians daily, and some of the fellows or residents, but the number is not constant. Currently, we are understaffed. We have 0 residents, but in general, it can be up to 6. So you see, it depends on the day. The average, it's 100, 120 patients per day. So if we are 2, we are quite a bit busy. So nursing staff, it's quite not so bad. It's 5 to 6 nurses. It depends on the shift as well, on the period, on the vacay, etc., etc. We have 1 to 2 registrars, and for sure we have up to 40,000 patients per year. What we talk, this is the last year. This year we see really increase in numbers, so I'm not sure where we are going. 50% now, when we started it was only 30%, now it's 50% of traumas, whatever trauma it is, minor to major, you know, accidents, whatever, and majority is self-referral. So I mean, walk-in, so I do call them self-referral. It's not even walk-in, so it's self-referral. They just, it would be nice to have referral, but they don't, they just come in. So in general, I will show you the landscape, because as Anna told, We have some as well emergency departments for pediatric, really dedicated for pediatric, but it does not mean that it operates in the same manner as we do. So if you have Lithuania, you see the map, we are quite compact, it's very nice. You can reach from Kaunas everywhere more or less 150, 200 kilometers, it's nothing special. So these red dots show you that we have emergency care for children. What does it mean? Emergency unit where pediatrician comes from the ward to check 24/7 on the patients. Yeah, is it comfy? I don't know. We know that all those patients come to our units, to our capital, because they're not happy, because those units do not provide, for example, trauma care, surgery. They sometimes do not have X-rays, even, ultrasound operating 24 hours, etc., etc. So a lot of decisions, even parents do not go there directly. They just go to the university hospitals. 3 centers, we have bigger ones, which have PICU close to the units, which have, surgery, trauma surgery, ENT, ultrasound, CT, working, operating, but all the severe cases anyway go to university hospitals, to Kaunas and our capital, Vilnius. We have Vilnius, which is why it is not together with Kaunas, I will tell you, because they have not one door income. What does it mean? They have separate trauma and surgery. So the pediatrician or pediatric emergency physician actually pediatric emergency physician is working in the surgery part and trauma, and pediatrician is separately working only for the whatever reasons, other reasons, And only one center, our center has it like that when you come, no matter with whatever condition you are with a foreign body, with a laceration, with burn, with trauma, with abdominal pain, with allergy, whatever, even infection. We have infectious hospital, we send them after, primary investigation, but anything, you have anything, we take you in, and then we decide what to do. So this is how our department looks, So we have waiting area, which is divided to infectious and not infectious area first. We have triage room, we have registration for sure, we have procedural room and small shock room for some small, procedures, etc. We have this orange for investigation or observation or investigation rooms, then isolation room, 4 white rooms. This means for longer stay, for no fever patients. We have 4 for these blue ones for up to 4 hours observation, let's say. We have a block of shock rooms, which is a bit further, like 5 minutes, not 5 minutes, oh, it's too long, no, maybe 30 seconds, because if you go slow, it's 5, but if you run, it's 30 seconds, maybe even 15 seconds. So this shock room, it's connected with, for example, the ambulance, which is coming, and we are already prepared because the ambulance is calling us already, hopefully, in majority of the cases. And we are there. One of the rooms is dedicated for pediatrics only, but we are connected with other rooms in case of disaster, and whatever. And this room is connected to CT. We go directly to CT if we need. And we have another room totally only for fever patients. So in case of COVID, for example, it was really easy to manage, because it was really divided very, very clearly. And for sure, we have some specialist rooms. We have 24 hours ultrasound, X-ray, CT. We have these specialists 24/7 operating in neonatologists as well. And we can call neuro, onco, endo, but really we do, I'm sorry for that, we can't deal with those problems. We really, really do. We do think that they can sleep during their night or weekends, so we deal with those conditions, or in case if it's super severe, we can call resuscitation team, for example, as well. And we have a really good, social worker with us during the working days, because there are a lot of social, a lot of social issues as well. So let's go further. So let's deconstruct the shift. How does it look? Who is working there? So in majority of the times we have 2 physicians. Those 2 physicians are pediatrician plus PICU physician, or pediatrician plus emergency medicine physician. I do like the latter one the best, because I will tell you afterwards why I do think it's the best combination. And we have fellows or residents. It depends. Sometimes we have one emergency physician, one pediatrician, from 1 to 6 GPs as well, but those are residents. You need to understand that, for example, GP can be from first year to the 4th year, you know, so their experience is quite different in this stage. So we have 5 to 6 nurses, registrars, and social workers. So nurses are divided into triage, observation, procedural, or trauma care. One triage to observation, procedural, trauma care is one. If we have this nurse, sometimes it's not present. And physicians are quite busy because they run 18 beds. They run incoming patients, whatever it is, it's trauma, it's, you know, not trauma patient, whatever. And they run trauma team, they lead trauma teams as well. And for sure, during the weekdays after 6 p.m. and during vacation days or weekends, they are consultants for 2 pediatric departments, which consists with 60 beds. But the running physician is resident, 1 or 2, so we consult them on whatever matter, if we refer the patient to the ward, etc., etc. And we are, as a consultant, we become as a consultant for any pediatric patient on other departments. So you can imagine how it's happening sometime during the weekend. It's fun. If just, yeah, sometimes we argue, you know, about if we need this, but yeah, life is like this. So let's go further, and I will tell you why I do believe this combination of physicians is the best. Okay? I think I will convince you. Because if you want to deal with more than fever, let's say, or abdominal pain, if you want to deal with traumas, and you have to, because people seek guidance, people seek care, and they will go to the best. They do not want to spend time to be referred to 100 specialists, you know. They will go directly where they can get help. So we have trauma teams as well. We have neonatology, so this is a broader, a lot of things to deal with. We have wounds, suturing, sedation, burns. We have stabilization, because PICU does not take patients like this. You need to stabilize those patients until the PICU. Actually, and it happens in emergency. We have ENT, eye, whatever problems you can imagine. So I do believe that pediatrician plus emergency physician, or PEM in general, pediatric emergency physician, is the best choice for this. And especially if the department is close somewhere in the periphery, in the rural area. So this specialist is equipped with every knowledge. They do not, as Anna showed, they really know the protocols. The X-ray, the CT scans decrease because you follow the protocols. You know when to do, you know the red flags, etc., etc. So there are a lot of benefits for that. So as Anna showed, I can just repeat, it results in a lot of benefit for a patient's safety, for less hospitalization, for less hospital-acquired infections, for, I don't know, for shorter lengths of stay, because parents do not want to be there in the hospital forever, like 10 days or whatever, observations, etc. So they want really fast solution, as fast as possible, and fast referral home as well. So they are more satisfied, they are more compliant. Just we can survey all the parents if they want to stay for the procedure in the emergency or they want to be hospitalized. The majority of them will choose to be in the emergency. And for sure, if we even hospitalize those patients, the outcomes are better because they are stabilized already in emergency department. So in case you have really severe cases and you don't know what to do, we have a team of resuscitation. It consists from PICU nurse and PICU physician. They can come on site as well. This department is closed. They are just, I don't know, 1 minute, 2 minutes until you stabilize the patient, they are coming in. Or you can call in advance if you know that ambulance, for example, is bringing the child. So who and how is referred to us? So as Anna showed, really nice referral pathways. We do not have them. And as you saw, it's like 80%, I guess, self-referral. Oh, I think I have an emergency and I go. So this is like that. But we have 3 pathways. So first, other hospitals refer us. This is pediatrician, secondary care, or whatever. And the primary care, in majority of the times, it's GPs, and for sure, by different reasons, self-referral. So if we talk about other hospitals, we have really limited resources. For this reason, other hospitals refer the patients to the university or tertiary care hospitals. They do not have any like experience in traumas, in burns, in even surgeries. There is no surgeon or what I showed you on site. And due to reform, we have this outcome due to reform because COVID happened, and a lot of hospitals, pediatric hospitals, due to the first no pediatric patients were sick or so hard sick with COVID, so they were transformed into adult units, and it never came back to pediatric anymore. They said, the periphery does not have a lot of children, so it's okay, we just close the unit, and they never reopened. So we have this first issue like that. And other issues that during COVID, some older colleagues as well, they left the unit and it never reopened because there are no pediatricians anymore to reopen a unit. So there are a few problems. Another problem is for sure primary care, and I will show you the numbers. It seems that there are a lot of GPs, but they are not. So GPs are not accessible in periphery especially. So definitely patients or parents gonna seek the guidance, whatever, and sometimes they do not access primary care because of teleconsultation. They want a live consultation, not a teleconsultation. I am telling, let's say, the GP that my child is coughing for 3 months or whatever, but they say, teleconsultation, okay, the cough seems wet a bit, so okay, maybe this one. So they are really seeking the guidance, not even going to GPs. They are really going around the GPs, and we do not like it when they come with those problems to emergency because it's not emergency even. So we have actually a reform since 2025, early 25, that pediatricians will be back to primary care because it was thought differently, and they will cover as well a lot of problems. We do hope, and they will cover, I hope, this what is lacking in GP. I mean, I will show you the numbers that the GPs are not as scarce really in the regions. And self-referral, the problem is that there is actually public insurance in majority of the times, and there is no charge policy. What does it mean? That they are not charged for anything. I mean, you can come with whatever reason, 1 year of cough, 3 months of trauma or whatever, just to consult, or feeding problems for 1 year, or what to eat, what not to eat. So there is a lot of issues like that. And for sure, if they don't have access to primary care, if they don't have a functioning department on the region, for sure they're gonna go to emergency department. It's not only our emergency department sees this, capital sees the same. So since this year, we have a really specific reform targeting emergency departments. This is for our benefit because we have a categorization, 4 categories, as you know, let's say from red to green. So now we have a blue category, which is not emergency, just maybe urgency, but this is a general GP category. Those patients who should go to GP but went to emergency, and GP is going to be charged. The polyclinics and primary care will be charged for those patients, and we will get the money. So I am super happy. I don't know about you, but yeah. So we can handle any patient, because we are a team of pediatrician and pediatric emergency physician. So we can handle any patient, but we need to understand that those patients just prolong the line, and you can miss some severe cases when you have those blue or even green patients on ward. Yeah, and let's go to the map. I promised you to show the lack of GPs and the lack of pediatricians. So you see that GPs, actually, the lower one, they are lacking in all the regions. So definitely, if the patient does not reach the GP, they will come where? To the emergency department to seek for pediatricians' help or for emergency physicians' help, in any case. And in Kaunas region, And nearby, we do not have even pediatricians operating well. They are as well older. They just quit due to different reasons. First, it was told that GP is gonna care only for primary care, so they're gonna transform. Some of them transformed their license to GP license. You know, there are a lot of issues. So for this reason, we do not have pediatricians. And this is again, if you don't have access to pediatrician or GP or anything, you go where? To emergency department. So there are a lot of problems. Again, patients are increasing. If you see during the time from 2000, let's say 12, this is really severe numbers. And this is a graph of pediatricians, so pediatricians in training and pediatricians operating afterwards. So really, this is a graph of last year, for example, and more years back. So in few years, in 10 years, because the pediatric population is getting older, we as well gonna crash if it's going like this. And even the emergency departments won't be covered by anyone. We have decrease in pediatricians and lack of emergency physicians as well, because this is, you know, quite a severe specialty. You need to know a lot, you need to work long hours, shifts, nights, etc., etc. So you see, there is a lot of things. So what about the future? And Anna showed very nice. So the future needs to answer one question. Do we need pediatric emergency medicine in general, like separate? And do we need pediatric emergency doctors, like separate, you know? Because I agree, this is not pediatrics, and this is not pediatric intensive care. This is not anesthesiology, this is not trauma. This is everything a bit combined and a bit separate. Trust me, we opened the unit 2016, and we had 2-3 years, hard years, until we convinced the specialists especially that we are totally different. We are a totally different unit, operating on ourselves. We are not slaves for anyone. We are not taking your patient and doing what you ask, because we can decide on our own. We know how to deal with a lot of problems. Maybe not as a specialist. I do not want to as well tell that specialists do not know emergency, but I want to tell that we do not know the deep, let's say, genetics, like rare diseases maybe, to treat them, etc. But we do know how to deal with urgency and emergency. Urgency and emergency, like a poem, you know. So I do agree, and I want to convince you that pediatric emergency physicians are necessary. And I already told you a lot about why it's necessary. Anna showed really nice articles about that, proving it scientifically why it's necessary. And another is that we care from neonate to teenager, or maybe even longer. It depends on the law, on the local law, because sometimes you can care for up to 21, 23 years. And they do like it, this transition, because adults' emergency can be a bit harsher, let's say. Yeah, like being honest. Yeah, so they do not like referrals, so pediatric emergency can summarize all the problems, can refer, like can call the, let's say the specialist if necessary, but in majority of the case, we can deal with that. Trust me, with traumas, with neurology, with endocrinology, with resuscitation, with like intubation, anything. And just to tell you what's about the training for the whole, why we are talking about that. So pediatricians are trained for 4 years for general pediatrics, really scarce in emergency medicine. Some, you know, now for 2 years we have it more, and I will show you, but they have really basic, a lot of specialized things, really not emergency medicine related. Pediatric PICU, it's again 6 years, but those 2 years, additionally to pediatric training, they have really more focused anesthesiology, let's say, but specific neonatal ICU, etc., etc. So this is very specific. We have emergency physicians. Our emergency physicians are really good trained in pediatric, and I agree with Anna. Now it's easier to attract them to PEM than pediatricians, because some of the pediatricians do not like pediatric emergency, but they have 1 year plus 4 months in the 5th year, so 16 months training in pediatrics, in neonatal care and so on. But again, they do lack a bit of some inner medicine, let's say, internal medicine, some neurodevelopment, some things very, very small things which you need to deal in emergency department as well. And if we talk about family physicians, so we have 4 years, and currently we have 6 months of pediatrics. This is 2 years now. Before it was 3 months. So you can imagine what difference it is in pediatric training in general. So going further, I will tell you that I do believe, and I do think, and we seek this in Lithuania, to have 2-modal system. It means that pediatric emergency should cover 2 specialties, or 2 specialties can be involved in that. So it's emergency physician with a specific additional training in some specific matters in pediatrics, or pediatrician with specialization of specific emergency matters, let's say. And we do have, again, some pediatricians who are really interested only in pediatric emergency medicine. So we do really need to think about that and to provide this, this model to think somehow out. So just to show you how we are developing, so 2013 we were just implementing emergency medicine because it's the first resident started in 2013. 2016 our center was built. Actually, it's really functional. 2018, the first fellows, the first residents finished, emergency medicine fellows finished, and they started to work. Most of them stayed in our hospital, but in Vilnius as well. But they are still lacking. Like we have 70 maybe emergency physicians per Lithuania. In 2023, we implemented competence-based learning in residentship, and in pediatric residentship, we included a few things additionally to what they had. So it's trauma. Trust me, not everyone is super happy about that. Trauma care, suturing, POCUS, etc. And in 2024, we've changed the license that they can do it, and they have to do it because it's in their license. Again, not everyone is happy about that. So the majority, for sure, they can choose to work in the regions in primary care if they do not want to work in emergency. And now we have 25, and we will see where we'll go. And so that's my message for you from Lithuania, and I thank for your attention. Those are some photos from our emergency. If you are more interested and keen to come to visit us, so you're welcome. We are always open for visitors and to guide you through our department, to show how we teach, how we provide the care. So just feel free maybe to call before, but in general, just come. Okay, thank you.
Thank you, Lina. And now we have time for questions. All the presenters will be there, and I asked the Tartu University Hospital presenters be there as well. Et kõik võivad esitada küsimusi eesti keeles, et ma tõlgin, sest et kahjuks ei saa välisesinejad meie keelest aru. Kohe ma tulen. Pane mulle mikro. Siin on olemas skanneerimise võimalus, et kes telefoniga skanneerib, siis saab tegelikult esitada küsimusi ka elektrooniliselt, et kes ei julge püsti tõusta ja küsida. Kõik on puudu. Ei, haigekassa esindajaga. Et alustaks siis, et kas on saalist küsimusi? Ma alustan siis ise. Tuli.
Kõva hääl muidugi ka, aitäh. Tuli Metsvastlastekliinik, Tartu Ülikool. Aitäh Ülle toomast lauale seda suurt ja olulist teemade ringi ja mulle tundus, et siin oli rohkem kui üks küsimus. Ma küsin praegu eesti keeles, sest see võib-olla on rohkem eeskätt meie juures või meie situatsiooniga seotud, et haigete hulk versus personaliprobleemid versus elanikkonna jaotus ja vähenev laste hulk, et mida sa sellest esile tõstaksid või kas sa näed, et Pediatric Emergency Medicine lahendab selle kõik?
Ei, ma ei arva, et see Pediatric Emergency Medicine lahendab, sest et vaadates Soomet, et kui vähe oli neil keskusi, mis tegelevad lastega võrreldes meie nagu populatsiooniga, et meil on tegelikult võimalik üldhaiglates saada mingil määral ka pediaatrit, et võib-olla tulevik on kindlasti rohkem keskustesse orienteeritud ja ütleme, et tegelikult võib-olla koht ainult sellele laste erakorralise meditsiinile oleks võib-olla Tallinn. Et ja seal on ka tegelikult võib-olla lihtsalt sellepärast, et meil ei ole seda trauma poolt.
And my second question would be more dedicated to the pediatric emergency, if allowed. You referred to that the units starting from 11,000 referrals are those that are planned to have pediatric emergency specialty. Why this limit? And would you see, you also said that they need to be trained outside Finland, which is still so much larger than Estonia, how to keep up the experience within the units?
Those are really good questions. Thank you. The 11,000, I actually don't know where the number comes from. It is from UK. And they, for some reason, have ended up with 11,000 patients a year. Don't ask me. But I think it is somewhere there. If it's a really small emergency department, like 10, 20 patients daily, I don't think maybe then pediatric emergency physician is not necessary. But what I think in Finland is that every emergency department seeing peds in our country should have a trained pediatric emergency physician who's responsible for the unit. That's my idea and my opinion. Where the 11,000 comes from, sorry, I don't know. To the other question, that those who want to be trained in pediatric emergency medicine, that they should be trained abroad. At the moment, yes, because we don't have pediatric emergency physicians in Finland. I'm the only one. So that's the problem. So we need someone to train them. So for now, in order to get real good training, I recommend them to go abroad if it is possible for them, for family reasons, whatever reasons. Most of them want to, which is really good. But I am hoping that we could actually then, in a few years, start training pediatric emergency physicians in Finland. Helsinki is the only place, though, that is big enough to train. But that's enough, because Helsinki trains a lot of other specialties as well in pediatrics. The other emergency departments are not big enough for get enough numbers and get enough training. But for now, the only places to train abroad, as I did, I've got 2 younger colleagues going to Stockholm next year, and there's 2 who's applying to Toronto as well. So they're actually really keen to going also and seeing what it is.
On saalist veel küsimusi? Palun, Kadri.
Meil on väga mõnus kooslus laua peal ja puhtalt eestikeelne küsimus Eesti inimestele. Doktor Toona perearst, doktor Vaas lastearst ja doktor Uustalo, kes teeb kõike, mis puudutab lapsi.
Ei kõik ei tea.
Ja öelge see mõnus pilt, mis teid kõiki 3 rahuldaks, niimoodi, et lapsed saaks abi ja kulud oleks tagasihoidlikud.
Mina ei ole varem sõna saanud ja mina olen perearst, töötan Linna perearstikeskuses osakoormusega ja töötan ka Tartu Ülikoolis peremeditsiini kaasprofessorina. Ja ega meid ju teeb perearstidena ka murelikuks see, et EMO-sse pöörduvate patsientide hulgast, kui me räägime lapspatsientidest, Tallinnas on üle 80% on rohelisse rubriiki kuuluvad patsiendid ja eks nende osakaal on ka mujal suur. Ja siin sai just nagu välja toodud ka seda statistikat, et see pöördumiste arv on järjest suurenenud ja olgem ausad, see pöördumiste arv tegelikult EMO-desse suureneb ju kogu Euroopas, kui me vaatame, et ega me siin vähenemistendentsi ei näe. Ja siinkohal ma tegelikult tahaksin tuua hoopiski teisest valdkonnast näite, et meil linnades võivad olla probleemiks autode ummikud ja mida laiemaks me ehitame teid, mida rohkem me neid asfalteerime, siis tegelikult ummikud lähevad ikkagi järjest suuremaks, sellepärast et autodega on järjest mugavam sõita ja sellisel viisil järjest enam ka sõidetakse. Ja kui nüüd võrrelda väga ammust aega, 80-ndaid, 90-ndate aastate algust, siis jaoskonna arstide töö oli korrastamata võrreldes sellega, mis ta meil praegu on. Me oleme tegelikult peremeditsiinis väga palju oma patsiente koolitanud, nad ei tule enam troppis meile ukse taha ja ei oota meil 2, 3, 4 tundi. Närviliselt, kaua selle eelmise patsiendiga läheb, meil on tegelikult iga patsiendi jaoks oma aeg, kus me teame, et me saame pühenduda ainult temale ja siis, kui on juba järgmise patsiendi aeg, ta tegelikult ei oota meil ukse taga pikalt, ta tuleb meile juba sisse. Aga selline korrastus tegelikult tähendab ka seda, et ka see äge lapspatsient, kes samal päeval tegelikult meil saab vastuvõtule, ta ikkagi peab võtma meil telefoniga ühendust või ta võtab meil arvuti teel ühendust. Meil on enamikus perearstikeskustes, kui ka telefonile kohe ei vastata, meil on olemas telefoni need jaamad, me näeme, kust on helistatud, me helistame tagasi, aga see ei toimu sekundiga. Meil on olemas enamikus perearstikeskustes digiplatvormid, kus need niinimetatud padid, kus patsient saab kirjutada, jällegi me helistame neile tagasi, aga see ei toimu ka sekundi pealt. Mis tähendab seda, et lapsevanem, kes võib olla väga mures, kellel on tänapäeval peaaegu kõigil olemas autod, lihtsalt otsustabki, et ma ei helistagi. Ma lähengi kohe kohale. Või ta proovib ühe korra helistada, tal kohe vastust ei tule, ta peaks võib-olla natukene ootama, see seisund ei ole üldse nii erakorraline ju, aga tal on hästi lihtne minna EMO-sse kohale. Ja siinkohal ma nüüd küll väga vabandan, õppida on kindlasti nii Leedu kui ka Soome kolleegilt, aga mulle endale tundub küll, et meil Soomest oleks praegu rohkem õppida, kus selline walk-in on ikkagi nagu rahvast on ka hästi palju koolitatud, et sa võid küll kohale minna, aga kõigepealt helista palun. Meil see analoog oleks siis 1220, kust sa siis saad suunamise või sa saad oma perearstikeskusest suunamise ja siis sa lähed juba EMO-sse. Et EMO-sse jõuavad ikkagi eelselekteeritud patsiendid, mitte et nüüd mitte ühtegi rohelist patsienti enam seal ei oleks. Selge on see, et see eeltriaaž ka ei ole ju 100% ideaalne, aga see koormus roheliste patsientide osas on ju väga palju mõistlikum. Ja me teame ka seda, et EMO-meditsiin on väga kallis. Ja praegu meil EMO-de peale kulub, ma ei räägi siin ainult lapsemodest, see on üleüldiselt, kulub tegelikult 1,5 korda rohkem rahalist ressurssi, kui kulub tegelikult kogu peremeditsiini ja selle sama 1220 telefoni ülalpidamiseks. Ja pean tunnistama ka seda pattu, kui minuga, me oleme oma patsientidega ju igas võttes nagu koolitanud, et kui ta võtab minuga digiplatvormi teel ühendust, meil tegelikult õde hoiab kogu aeg sellel pilku peal, ma juba loen sealt, et tõenäoliselt tegemist on patsiendiga, kes vajaks haiglaravida, ta on näiteks dehüdreerunud, nii palju oksendanud, kõht lahti, ma helistan, täpsustan selle lapse seisundi veel üle ja palun tal pöörduda EMO-sse. Ja tunnistan pattu selles mõttes, et praegu on see ligipääs nii vaba, et ma jätan vahele selle, et ma ei kirjuta tegelikult saatekirja. See on mulle nagu minu tihedas tööpäevas, see patsient võetakse seal kogu aeg vastu. Aga kui see töö oleks natukene teistmoodi korraldatud, siis ma loomulikult teeksin selle saatekirja, see ei ole minu jaoks üldse mingi vaev. Et need samad, kui ma vaatan enda perearsti seisukohast, siis need samad ägeda haigusega rohelised patsiendid on minu töös ühed väga lihtsad patsiendid. Nende ülevaatamine tegelikult nõuab väga vähe aega. Nad on need rohelised patsiendid. Jah, tegelikult on ju lihtsalt, nad vajavad nõustamist, aga ma enamasti ju tean seda peret ka varasemast. Mul on väga palju pingelisem töö nende multimorbiidsete patsientidega, aga see süsteem vajab korrastamist ja see muidugi nõuab ka teatud määral poliitilisi otsuseid, sest see on lapsevanematele mingis hetkes nagu ebamugav ka, kui me seda süsteemi muudame, aga see süsteem, nagu te Soome näitel kuulsite, siiski on täiesti võimalik. Aitäh!
Kommenteeriks ka enda poolt, et mina siis Hannes Vaas olen Tartu Ülikooli Kliinikumi lastekliiniku lastearst ja töötan põhiliselt meie EMO-s. Esimene eeldus selle jaoks, et meil EMO üldse saaks korralikult töötada, tegelikult algaski sellest, kui me kolisime uude majja, meil on sisuliselt 2 korda rohkem ruumi, kui meil vanas roosas majas oli. Meil on võimalik täita kõik need tingimused, mis siin eelnevalt olid selle oranži kastiga toodud, et vähendada hospitaliseerimist, parandada patsientide rahulolu, pakkuda paremat ravikvaliteeti just seal algusetapis, mis eeldab ka seda, et on vastav personal, et on õdede arv suurenenud ja arstid muudkui koolitavad ennast sellel alal rohkem. Kas Tartus selline inimene nagu laste erakorralise meditsiini arst oleks vajalik, on muidugi omaette keerulisem teema, sest meie pöördumiste arv on alla selle 11 000 piiri esiteks, aga kui arvestada sellest, et kui palju sealt on tõesti neid rohelisi patsiente, keda saaks käsitleda muud moodi, neid patsiente, kes päriselt vajavad intensiivravi, on aastas alla 30, kes lähevad EMO-st otse intensiivi. Et kas selle jaoks nüüd eraldi valveringi välja koolitada Tartu suuruse juures on küll küsitav. Õnnelikuks mind teeks küll see, et arengud peremeditsiinis jätkuvad nii, nagu ta on praegu jätkunud, et näen oma igapäevapraktikas siis neid patsiente, kes on teil kinni püütud selle digilahendusega ja siis jõuavad meile ja need on tõesti hästi kinni püütud. Aga kindlasti meie 1220 kvaliteet võiks veelgi tõusta sinna tasandile, mis me nägime siis Soome kolleegi poolt.
Jah, see süsteem, mida soomlased kirjeldasid, tegelikult ju tähendab ka seda, et kõik lähtuvad nagu enam-vähem ühtsetest algoritmidest, et seda me ju tegelikult praegu ka Eestis veel ei tee selle triaaži osas.
Seal on algoritmide osas on positiivne see, et meil on Tartu Ülikooli Kliinikumis valvearsti käsiraamat, mis tegelikult annab algoritmid enamustele levinumatele lastehaigustele, et sealt poolt siis tagada, et see ravikvaliteet oleks ühtlane mitte ainult meie 26 valvearsti lõikes, vaid ka tegelikult väiksemate haiglate lõikes, kellega me koostööd teeme.
Ma küsin sul vastu, et kas seal, mina näen seda, et kõik on väga ilus, kui on nagu perearstil hea tunne ise laste teemasid vaadata, aga tegelikult on meil ju ka igal erialal väga suur varieeruvus. Ja see loomulikult paraneb, aga ma tunnen, et päris palju perearste tegelikult ei tunne laste osas hästi ja kindlasti neil ei olegi seda lastearsti käsiraamatut, et nad ei et nad vajavad vahel ka lihtsalt lastearsti lisakonsultatsiooni, see peaks olema, ja ma olen päris kindel ka see, et 3%, kes meil on seda, kes tuleb saatekirjaga, väga palju on tegelikult suunatud ka lihtsalt suuliselt, et samamoodi, et ma ei jõua ja et minge EMO-sse. Jah. Aga natuke ma tahan Anna käest küsin inglise keeles, et ma olen natuke pessimistlik selles nagu, et meil on mingid nõuded, et inimesed on erinevad, riigid on erinevad, ühed on väga nagu, ütleme, kuulekad, see rahvastik on väga kuulekas, eestlased ei ole väga kuulekad.
Eestlased tegelikult perearsti juures aja broneerimise on väga hästi ära õppinud, ma ei oleks väga pessimistlik.
Aga mõtlen, et ma tahan ja ma tulen, et ma tahan ja see, et vähemalt, et mulle tundub vähemalt niimoodi, et nagu vaktsineerimine näitab.
Seda me ei saa tegelikult nagu loota, et me kogu aeg koolitame patsiente, see tee on vaba tulemaks, aga ütleme, et teate, me koolitame teid, ärge tulge, aga tee on meil täiesti vaba. Et siin peab tegelikult midagi natukene süsteemis ka muutuma. Jällegi ma toon teise näite. Seesama autodega sõitmine, me võime inimesi kogu aeg koolitada, palun sõitke ühistranspordis, see on loodusele palju kasulikum ja nii edasi. Aga kui väga palju mugav on sõita autoga, seal peab natukene midagi ka süsteemis muutuma. Koolitus on ka muidugi väga hea ja sellest on palju abi. Teisalt, mis on ka muutunud, on see, et elutingimused on muutunud hästi aaraks, pered elavad eraldi, vanavanemaid ei ole, et teinekord ka just sellised lihtsad asjad nõuavad, mida varem võib-olla pere sees ära lahendati, nõuavad nüüd rohkem nagu tervishoiutöötaja abi, ükspuha, kes see siis ka parasjagu peaks olema.
Võib-olla ma küsin vahepeal Anna peast, et see aitab meil vastata. Anna, can you a little bit explain how do you keep these green or simple patients away from this high-level referral centers, because our patients, they don't follow the rules. They're just, I want to come and I'm coming. Why I need to go to family physicians? I want to go to the highest level, but you said it's 30% are only green ones. They're going to this terveyskeskus. Voiko, please explain.
Well, generally the Finns do follow the rules. So that's one of the things, probably. I think one of them is that if obviously we have places where the primary health care does not work. It is similar, we don't have enough physicians, so on those places more patients go to the emerge. But emergency department, one of is that this number medical helpline, what I talked to you about, so that has brought down the number, that's one thing. The second thing is that at triage, if the patient does not need emergency care, they are sent home.
Okay.
So they are told, get contact to your primary health care tomorrow, or maybe a nurse just tells there's nothing you need to be worried about, you don't need to see a doctor, you don't need to come in, and they will send them home. So, or refer to the primary health care. So that's pretty much what happens.
But they are satisfied because our patients, they say, I don't want to see the doctor, I'm not satisfied to nurse.
That is, I think that's something we've had 5-ish years ago, and we've been teaching them. And even this medical helpline, the phone number you call to, they do not tell you that go see a doctor. They tell you go see a professional, go to the primary health care, go to the emergency department. They don't tell them who to see there. And that is one of the things that we've been kind of strict about, that the nurses who answer that phone, they never say that you need to see a doctor. They say that you need to see a healthcare professional. If they come to the emerge and they do not need a doctor, they will meet a nurse, and they can either be happy with it or not, but they will not see the doctor. Obviously, there are always cases that will demand, and our nurses will not start a fight with them, but generally it has been getting better and better. It needs work from the emergency departments and, sadly, from the nurses in the front line.
But you don't use any financial tickets for that. It's coming directly to the third-level hospitals. It was before. If you turned in, it was 20 years ago, I think, in Finland. You can't come directly to the emergency.
Yeah, exactly. Yeah. So. As I said, you can come, but you will not be taken into the emergency if you don't need an emergency care. If you don't need care today, so you're not going to be seen. I don't know if that was...
Yeah, no, I mean it's the financial, and you need to pay for that if you're coming.
Oh, yes, you do. It's 35 euros or something like that, what you pay for when you come to the emergency department and see a doctor.
How many?
35 euros, I think,
okay.
or 40-ish, somewhere like that at the moment.
Just to clarify, if the patient, the child with parent, comes to the emergency department, but triage nurse considers that it's green patient, then it's not taken in.
It depends on because green patient can, in our triage system, green patient can be a patient that needs to see a doctor still.
Yeah.
But if we consider that they do not need a doctor at all, they will not be taken in.
They might need a doctor tomorrow or day after tomorrow. They are sent home. Or then we have a possibility also to see a nurse, a specific nurse that will take a little bit more time with the patient and go through some basic issues like, we say, gastroenteritis, not dehydrated, just give a little bit more information to the parents and how to treat and so on. So that might happen, but they do not need to see a doctor.
But you also, in your lecture, you have possibility to refer to GP if they're coming in some cases. You have like GP working in your department?
Yes, we in most of the emergency departments, we do have to, by law, have GPs as well. So they see the easiest patients. Because as I said, there are patients that need to be seen by a doctor, maybe not emergency, but the nurses still think that this patient does need a doctor so that we can get this situation solved. So they will see the GP in the emergency department. If they do not, if they consider, okay, they can wait till tomorrow or day after tomorrow, then they will send them home.
Ja mõtlen, et vastus Kadri küsimusele, mis mulle tundub, et miks meile pöörduvad, on üks asi mugavuspöördumine, teine asi, mis ma tõin ka välja, see juba 20 aastat tagasi Šveitsis, kui sa tõstad taset, et sinu teenus on parem, kui sa saad näiteks, et perearstikeskuses ma ei mõtle teadmisi, ma mõtlen, et ma saan analüüsi järgmine päev, ultraheli on 2 kuu pärast, mina arvan, et ma tahan seda ultraheli saada, ma tahan seda röntgenit täna saada, et siis ma tulen selle arsti juurde, ma saan kõik koos. Jah, ma tean, et ma pean ootama, või siis, et aga ma tulin just reisilt või mul on nüüd vaba aeg ja ma tulen sellel vabal ajal, et tegelikult on meie piigid, millal pöördutakse, on kell 12 hommiku, 11.12 ma olen ärganud, ma tulen ja teine on kell 6 õhtu, kus ma siis tulen lasteaiast koju ja siis ma võtan lapse ja siis ma tulen. Et see on selline nagu üldine mugavuspöördumine, mis on ka pangas, et ma saan kogu aeg küsida, et ma tulen endale meeldival ajal. Kui see vastab Kadri küsimusele.
Do you have any plans to reduce walk-ins in Lithuania? Or perhaps any recommendations for us?
Yeah, so we do have plans because it's increasing and the walk-ins in majority of the time is green and not even sometimes requiring. And from those green, we have like 70 to 80% green patients in our emergencies. It does not matter if our emergency or capital emergency or seaside emergency, it does not matter. And from those, maybe 30 to 40% are blue. What does it mean? That they do not need even maybe GPs? I don't know. I mean, in general, there are a lot of problems, but we want first thought is to install another physician in the triage room, just to do not only with the nurse, like the team, because sometimes nurse cannot, decide finally if they need to be sent home or to another, let's say, to GP or whatever. And this is, I do think I agree with Anna that this is a culture you need to build, because our patients, it was never like this before, but it's a culture. They know the shortest way and they use it. I mean, you build the culture, they are angry at the beginning, everybody is angry in the beginning, but this is for patient safety, for lower flow, for less some missed cases, which are really very severe, because in this flow of patients, when you have 140 or our capital has 200 or 230 per day, you're gonna miss sepsis, you're gonna miss any kind of, severe case, or even endocrinology, metabolic or whatever, because everybody is complaining very close to the same symptoms. So, and everybody wants the best care because they live nearby, they know the tertiary care is here, neurologist maybe is here, and so on, and they're gonna go here not to wait. So we want this. Another idea was to have a GP on site, but I will tell you how it happened. So we never thought about GP in pediatrics, but it was a GP room in adult. They quit after 3 months, I guess, because the load was so big. They could not deal, because can you imagine, it's 80% of patients. So what does it mean? 20 patients are for emergency and 100 patients are for the family physician. It's impossible, because they do not come 2 patients per hour. They come like 1 patient per hour in the morning and then 40 patients in 1 hour in the evening. So, this did not work. Another thing we wanted to do, it's about this fast track, but I do think that it will never work when you have 130 patients, because from whom it's 80% green, because all of them should go to fast track. It's impossible. So only triage maybe would work. And another thing what's already installed, this is to charge GPs and polyclinics. It does not matter if there is primary care. Wait, let me finish. It does not matter if it's primary care for GPs or pediatricians. I mean, if those patients come, it's not weekdays, weekends, it's not, let's say, vacation days when the GP or primary care in general is not functioning, they're not working, but it's about those working hours during which GP should or primary care should function or should operate. So we will see. It's only a plan. It's only a start. We will see how it's gonna work.
Why you would punish GPs?
No,
if the patient herself decides to go to the ER?
Yeah, so
sounds to me like directly punishing GPs for nothing.
Yeah, well, I don't think it's for nothing. We can punish patients as well.
I have worked very long time as a GP,
yeah.
And if you have free walk-in, then you can't reduce the flow by punishing GPs. You have to change the system. So it's not so convenient to get the best pediatric care for the simplest running nose. That should be thought the system, not like is it in Finland, when they have less number of green patients. But your system is not punishing GPs. No.
So I do not represent governmental organs today because I'm not in government. It's a long discussion and they did it. I mean, this is like this, and we will see how it works because, let's say, about the charging the patient, let's say, it was started in some departments, but it never works. Yeah, exactly. So the culture was not there because, for example, in some regions we know they provide this technique, let's say, to charge the patient, but the administrative unit of the hospital, they give the money back to the patients afterwards. This is a lot of things. I want to tell you that Lithuanian system of healthcare in general, it's a very punishing for physician in per se. What does it mean? It means that you are guilty as charged before it's proven differently, okay? So a lot of things come from that. That patients do what they do. That patients do not go to GPs, they go to the fast whatever, to get a neurologist in emergency or whatever. And so there are a lot of basic on that. And for this reason, charging them, it's quite hard thing because, for example, I can talk for our administration of our hospital. It is never supported. You can do on your own if you wish, but you are alone. I mean, you can then, go in conflict for 1 hour, lose another 20 patients. I mean, you will never do this. So this should be a culture in general, the culture. So if I can update you in 1 year how it's gonna work with GP charges. I think for sure our GP units are quite strong and unities are strong, so we will see how it's gonna be. And if it's working, I don't know, because the numbers, the system is still on implementation. the numbers are still increasing. So I don't know if it's going to be, some kind of control. I don't know.
Thank you. I've just one question for Dana. There's I was talking a lot about in our system that we have remote places. And in remote places, there's pediatricians getting old. And how to replace them? I know that Finland has also very wide, very long, and there is a lot of remote places. How to provide care or how to provide consultation for them?
I think in northern Finland, they've gone furthest so far. So they use a lot of telemedicine. So they actually, the primary care physicians or nurses even can contact the physicians working in the hospitals. Emergency services can, as they reach the patient, they can have direct contact with either physician on call or the emergency service physician. So that's mainly what they do. I do work in the island, Ahvenanmaa, Åland,
Okay.
which is a tiny island with about 20,000 people living there, in middle between Sweden and Finland. It takes about 6 hours with boat to get to that island. They've got deliveries there as well. And I asked them that how much do they use telemedicine, kind of in normal, in basic situations as well, not just emergencies, and they told me that now we don't use them because the patients don't want to, they want to come to us, which was surprising because all the people live not on the main island, but on a tiny island around, so they actually have to take their own boat to get to the hospital. So patients do not want to use telemedicine all the time, even though they has the possibility. But in northern Finland, they have been working a lot with that. I'm not really that confident in that, how it works, but I know that they do a lot of telemedicine there, and they have tiny centers with just might be a nurse who can then contact the doctors.
Okay, maybe it's our way to go to the islands.
Ule, I can tell on that because for example, GPs have telemedicine. And still the patients want to come in. I agree because they want a live contact in majority of the time. So telemedicine is just a part of solution. Our emergency, like adult emergency, has a good system to consult the secondary care facilities. Let's say this is a bit better because then you have already, a physician's view and the patient is on site. But we were thinking about that as well too, because there are so many calls even, so maybe it's better for telemedicine, but I'm not sure because our GPs are doing, and the patient still has a teleconsultant with the GP, and they still, whatever, in 5 minutes they are there in emergency. So I'm not sure.
Okay, thank you. But it's just one final question because the time is up.
Ma küsin eesti keeles. Ühesõnaga, mul on lastearstidele, siin on rohkem lastearste ka. Nagu te ise ka nägite, et iga süsteem on erinev ja väga palju maakondades, Tartus, Tallinn, okei, sul on spetsialistid iga nurga peal, sa saad konsulteerida, aga kui me maakonda lähme, siis lastearstid on ikkagi pensionile minemas, seal ei ole ressurssi ja EMO-des ka ei ole ressurssi, seal ei ole EMO-arstid valves, seal võib olla abiarst, kes on 4. aasta, 5. aasta. Et minu küsimus ongi see, et mis on nagu see lahendus sellele, et lastearste tõenäoliselt ei ole tulemas juurde maakondadesse. Võib-olla on, ma võib-olla eksin, telemeditsiini variant, potentsiaalselt on, aga kas siis Tartu Tallinna arst, kes on valves, jõuab kogu aeg konsulteerida maakonda vaevalt, tal on oma tööd ka vaja teha, et mingi lahenduse me peame ikkagi tuleviku vaates välja mõtlema ja see nagu rääkis ka haigekassa või tervisekassa esindaja, vabandust, et kuidas last põrgatatakse ühest kohast teise, tegelikult saab väga palju asju koha peal lahendada, aga siis ongi see, et kuidas me neid lahendame nii, et ei peaks seda last põrgatama.
What is it?
Võib-olla tagantpoolt ettepoole tulles siis, et see esimene küsimus oleks see, et kuidas siis kolleegiga saaks hästi konsulteerida. Paratamatu on see, et enda töö on ka ja kui teised helistavad, siis lihtsalt peab tihti enda töö kas pooleli jätma või lihtsalt kokku leppima, et räägime mõne hetke pärast. Mul oleks hea meel, kui oleks võimalik selle konsultatsiooni raames patsienti näha, ehk siis see oleks siis mitte see see oleks siis telekonsultatsioon, ütleme siis niimoodi, et tihti pilt ütleb rohkem kui 1000 sõna ja kui on võimalik korra sellele lapsele otsa vaadata, siis saab ise ka natukene parem aru saama sellest, mida kolleeg teisel pool telefoni kirjeldab. Eriti kui tegemist on siis 4.-5. aasta arstitudengiga. Nüüd omaette teema on see, et kas see on jätkusuutlik, et meil arstitudengid tihti võtavad vastutava valvearsti rolli väikestes haiglates, omamata näiteks 4. aasta tudengina mingit pediaatrilist haridust. Nojah, ei ole ma selles osas väga optimistlik. Aga mida me saaksime parandada, oleks see, et tõesti EMO residentuuri raames, kui oleks see pediaatriline väljaõppe natukene pikem, et vähemalt siis need EMO-arstid, kes töötavad väiksemates kohtades, tunneksid ennast kindlamini laste muredega. Väga hästi tuli sinu slaididest välja ka see, et tegelikult enesekindlust oli päris palju selliste muredega nagu epilepsia, krambid, selle kupeerimine, sellised tõelised erakorralised seisundid. Aga kui tuleb koolikutes laps, siis on äkki väga keeruline, sest see on küll pediaatria siuke ABC, aga EMO-arstile jääb täiesti võõraks. Et just selles osas, et ka natukene rohkem pakkuda EMO-arstidele mitte päris erakorralist pediaatrilist tausta.
Ühesõnaga. Ja ei, selles suus küll, aga EMO-arste tõesti ei ole ka igal pool, et meid on ka väga vähe. EMO-residentuur ei ole populaarne, see ei ole üllatus, et selles suhtes meil jäävad kohad täitmata ja arstide peale tulek ei ole ka nii suur, et selles suhtes paratamatult on üldarstid ja abiarstid. Ehk siis peab mõtlema võib-olla ka üldarsti õppe peale, üldse arstiteaduskonna käigus, et võib-olla praktilisemaid asju või see ei ole minu valdkond, aga midagi peab muutuma, et päris nagu okei ei ole see, ma arvan.
Ja siin on saalis küsimused.
Jah. Katrin Luts praegult Haapsalus haiglas juhatamas ja oma erialalt lastearst ja pikalt olnud siis lastehaiglas. Ja mul on hea meel, et lõpus viimase lausena me jõudsime tegelikult üldarsti ettevalmistuse ja üldarsti kui sellise rollini üldse. On täiesti helesinine unistus, et me suudaksime ära katta maakonnad lastearstide või EMO-arstidega, EMO-väljaõppearstidega. See on mõttetu ressursi raiskamine ja see ei täitu meie võimete juures mitte kunagi. Minu meelest oleks tagumine aeg võtta suund ja saada aru, et perifeerias peab olema väga hea ettevalmistusega üldarst. Ja kes see näitas, kuskil oli ettekandes, kes tunnevad ennast kõige paremini laste küsimustes?
4.-5. kord.
Just nimelt, eks ju. No olgem ausad, nad veel ei tea, mida karta, aga seal on kindlasti ka see, et nad on olnud selle juures nagu, nii nagu keskkooli lõpetaja, öeldakse, on kõige targem, eks ju, kuigi kogemust ja praktikat ei ole. Nii et minu hääl läheb väga hea üldarsti ettevalmistusele ja see lahendab nii mõnegi probleemi, mitte ainult pediaatria.
Seal on veel üks küsimus. Kes?
Nii, mina olen Kristiina Tidemann ja ma olen Eesti arstiteadusüliõpilaste seltsist ja ma räägin siin tudengite eest, et ma olen ise 5. kursuse tudeng ja ma olen ka maakonnas töötav abiarst. Et võttes arvesse, et praegu planeerib Tartu Ülikooli meditsiiniteaduste valdkonna dekanaat arstiteaduse õppekava reformida, siis küsiksin, et kui palju peaks laste erakorralist meditsiini õpetama juba ülikoolis, võttes arvesse, et hetkel on arstiteaduse õppekavas olemas siis EMO-tsükkel, mis käsitleb ainult täiskasvanute kriitilise seisundid ja on olemas pediaatria-tsükkel. Et kas te näeksite, et arstiõppes peaks olema ka eraldi lisaks tavapediaatria ja täiskasvanute EMO-tsüklile kohustuslikus korras olema ka laste EMO-tsükkel. Praegu on võimalus siis 6. kursuse ajal võtta laste EMO veel eraldi, aga see on võimalus, mitte kohustus. Aitäh!
Mina võin vastata ühesõnaga, kuigi mina ei tee neid õppeprogramme, aga EMO õppeprogrammiga on nii see probleem, et see on rohkem intensiivipõhine, et ta ei ole ka päris veel EMO-põhiseks muutunud. Ma arvan, et see võiks, ma ei tea, EMO-tsükkel on suht lühike arstiteaduskonnas vist nädal oli, et sinna väga pediaatrit sisse ei jõua panna, võib-olla laste haigustes mõelda rohkem nagu pediaatrilise praktilise poole peale, erakorraliste seisundite. Ma arvan, et ma ei tea, kas praktikatsüklit oleks mõtet teha, teil ei mahuks tõenäoliselt vist praktiseerima ära kõik tudengid, kui nad hakkas 6 aega tegema. Või läheks keeruliseks, ma arvan, eriti EMO poole pealt, et võib-olla ikkagi laste haiguste nii-öelda õppesse sisse seda pediaatrilist EMO natuke rohkem, et valmistada neid. Kui nad, tõesti paratamatult meil kõik ei lähe ka residentuuri, me peame arvestama, et aina rohkem on trend üldarsti suunas. Et nii palju, kui ma olen näinud noori kolleege, nad ongi otsustanud EMO-desse tööle minna, perearstikeskustesse ja nad tahavadki üldarstina töötada, nad ei taha spetsialiseeruda, nad tahavad võtta aega, otsustada, aga siis ongi see, et kas see 6 aastat on piisavalt ettevalmistav kõige selle jaoks.
Ma arvan, et osaliselt te vastasite ka väga hästi oma küsimusele ise, et tegelikult see 6. aasta praktika annabki ju võimaluse, kui inimene teab, et ta perspektiivis plaanib töötada üldarstina väiksemas kohas, et siis võtta ka need vastavad tsüklid, et saada endale see maksimaalne parim ettevalmistus. Teises küljest, kui inimene teab väga hästi, et minust saab gynekoloog, et kas ta siis peab saama eraldi veel näiteks 6 aega laste EMO tsüklit arstiteaduse raames, et see on vist küsimus rohkem dekanaadile kui meile. Aga 6. aasta praktikat me kindlasti kiidaks ja see 6 aega võimalus praktiseerida laste EMOs tuleb kindlasti kõigile kasuks, kes tulevikus lastega tegelevad.
Ma võib-olla lõpetuseks me tõesti peame asju kokku tõmbama, et ütleks, et võib-olla samad tegelikult 6. kursus või ütleme see õpe, et kui me siingi vaidleme, mis asi on laste EMO, siis see võiks olla, et pediaatrias need sellised kiired asjad õpetatakse ikkagi sellel ajal selgeks, mida sul oleks vaja nagu üldarstina teada. Üldarst tegelikult läheb tööle ja ta ei saa mitte mingit koolitust. Ta töötab mingil ajal, et ta saaks teada, et kuhu ta läheb residentuuri, vaevalt, et keegi jääb kogu eluks üldarstiks, siis see kogemus tuleb ju ainult sellest, mida ta töökogemus on. Seda õpet meil ei ole üldarsti õpet ju.
Minu teada küll professor Metsvaht õpetab kriitilisi seisundid lastel.
Ma tõesti ei tea, aga kui inimesed küsivad, siis ma vastan, et... Aga me peame lõpetama.
Ja lastehaigused on seal sellises mahus, nagu nad on sinna mahtunud. Kus ma näen, on osa vastust teie küsimusele, on see sama praktiliste oskuste eksam, mida me oleme tõesti pannes kokku heade kolleegidega neid küsimusi suunanud sellele nii-öelda praktilisele tasandile ja sellele võib-olla rohkem tõesti, mis on igapäevatöös just nimelt vajalik ja oluline, alustades üldarstist või abiarstina töötamisest. Aga ma kindlasti kaitseks natuke seda akadeemilist haridust ka, et pediaatrias mingisugune hulk peab minema sellele, et ka see üldarst ja abiarst peab tundma lapse arengut, sest sellest algab tema hingamine ja kui seda seal ei ole, siis ma arvan, muutuvad paljud asjad palju keerulisemaks. Et eks see on kompromiss, nii nagu meie tänased võimalused seda lubavad. Kui see on üldine trend, eks me püüame neid kriitilisi asju siis jälle rohkem lauale võtta. Aga 3 akadeemilist tundi ei ole palju, ütleme nii.
Seda on väga vähe. Et ma arvan, et me oleme siin jõudnud lõpuni, kes tahab veel küsida, kõik lektorid on saadaval ja palun see viimane küsimus ja siis me tõesti lõpetame, et sest me oleme ammu juba üle aja, aga kui kõik tahavad nii küsida, siis palun.
Noored kolleegid kasvavad peale, aga vanad teevad tööd ja meditsiin on palju arenenud. Kas on võimalik maakondade emode laste abi parandada sellega, et keskustest tuleksid arstid, kes vaataksid üle meie töövõimalused, annaksid meile nõu, kuidas laste abi paremini korraldada, võib-olla teha mõni väike koolitus seni töötavatele EMO-arstidele, võib-olla konsulteerida ka pediaatrilisi haigeid maakonnas paari päeva vältel. Et me võiksime teha sellist koostööd maakonna haigla ja regionaalhaiglatega vahel, et kvaliteet saaks kiiremini parem.
Tegelikult ma vastan su küsimusele, et ma rääkisin eile, et teie terapeudiga, et kuna ma tean, et selle Tiiumaalt, et kuna teie ainus lastearst tõesti sügisel läheb pensionile, et võib-olla teha ümarlaud kokku, et mis saab edasi, et sest Hiiumaa ei saa jätta mitte kuidagi ilma kaitseta, sest et teil on sünnitused ja teil ei ole transporti, te olete liiga isoleeritud. Et võib-olla arutaks seda siis sellisel ümarlaual. Ja, aga ma arvan, et me oleme lõpetanud, et tänan kõik, kes osalesid. Ma loodan, et te saite kõike seda head ja paremat. Ja kui nad on veel olemas, et küsige isiklikult.